Hi, everybody. Thanks for joining our webinar today titled Improving Interoperability by Standardizing Newborn Screening Data in EMR Reporting. My name is Craig Newman, and I'm going to be moderating this webinar today. Just as a reminder, the INDSI project is a HRSA-funded project with the goal of reducing morbidity and mortality associated with heritable disorders in newborns and children. And we aim to meet this goal by enhancing the connectivity between public health care providers and state public health newborn screening programs. And our focus is really to prepare public health programs for particularly in the three key areas of dry blood spot screening orders and results, early hearing detection, and pulse oximetry results. Our approach is really to be hands-on with assistance to newborn screening programs to evaluate their current interoperability readiness and help them develop a plan to achieve their interoperability goals. We also facilitate discussions and collaborations between jurisdictions and programs, ensuring that as a community we can learn from each other and all make progress together. And finally, we provide training and education opportunities like this webinar. For program and for technical staff. And today's webinar is the next in a monthly series of educational webinars across a wide variety of topics, both technical, project management, practical implementation, and beyond. So we're very fortunate to have two great presenters with us today. We'll hear from Dr. Joe Schneider, who many of you know already from his work with our INDSI project. Dr. Joe is with the University of Texas Southwestern Department of Pediatrics. He's also part of the Texas Medical Association HIT Committee, the Texas Newborn Screening Advisory Committee, and the ACHD NC Follow-Up Committee. And apparently, in addition to all that, he still actually sees patients. I'm not quite sure how with that list of commitments. And joining him will be Dan Rutz. Dan is an integration architect with Epic, one of the prominent EHR system providers. He's been with Epic over 15 years and is one of their primary experts on the use of standards to share data between systems, particularly in the laboratory space. Thank you to both of you for joining us today, and I'll turn it over to you.
All right, Craig, thank you very much. This is Joe Schneider here. I have a couple of we have a couple of objectives today. Before I go into those, I just wanted to say thanks to the folks at INDSI, all the vendors who work with newborn screening and other health standards information, such as Dan, Brendan Riley, who I saw on the call, and many other people from whom I've built this proposal that for standardization, and I just wanted to say that I wanted to end. We wanted to end the content webinars. This is the last, at least for the moment, of the content webinars, with a dream and a hope. And so now let me get into our objectives for the next hour. Would be to show you some opportunities, some benefits, and then discuss some challenges in standardizing first newborn screening data. Lots of activity there, and we've talked a lot about that. But the new thing is standardizing newborn screening results displays that clinicians would see in their EMRs for blood spots and point of care hearing and CCHDs. And I'm not talking about displaying it within a particular EMR. I'm talking about standardizing the display for all EMRs. So with that bold statement, let's go on to the next page. So first, I always say, sadly, I have no financial or other disclosures to provide here, other than I'm on the INDSI board, the advisory board. And the caveat is that many screenshots are taken from an EMR that I use clinically, so that doesn't mean that the issues are only with that EMR. What I'm talking about really is common to all EMRs. So next slide, please. So first, I want to start out with an analogy. And next slide. So I want to take us back probably about 100 years ago. And I want you to all think about a time before standard traffic signs. And on the left, I've got two pictures of what stop signs looked like at that time. If you went to one place, you'd see a little pole and there'd be this little thing at top that said stop. It didn't have any particular, I believe it was black and white. Then there was the yellow stop sign, and of course the red stop sign that we're all familiar with evolved at some point. Now, thinking about that time and all the differences between the stop signs and other traffic signals, you didn't really have a problem if you didn't move between towns. Every place did their own designs and everybody was happy in those places. Nobody had to coordinate with anybody else, but eventually people figured out, aha, it's important that we have standards so that as people move from place to place, they're going to be able to understand what the signs mean. And so multiple conventions were held to get us where we are today. On the left-hand side there's a picture of the 2012 supplement of the 2004 edition of standard highway signs. We're now standardizing across the world as well. So next slide, please. So by hypothesis, is that we are in EMR development like we were with traffic signs 100 years ago. And so just like standardizing traffic signs had value, my hypothesis, if we standardize, starting with newborn screening data and EMR displays, that we can yield, this can generate significant benefits. So next slide. So first, a couple of slides about those benefits. So one of those benefits in talking just about standardizing data is that it becomes easy to share data. You don't have to convert data from one thing to another before you're sharing it, say in a health information exchange, or using tools such as FHIR or electronic case reporting, which is becoming increasingly used. If you have standard data, it's easy to grab metrics from databases across different programs because, again, no conversion necessary. And that allows you to organizations to participate in regional, national program improvement activities because everybody is reporting the data the same way. And by the way, this isn't a new idea, and I actually don't have any new ideas at all in this because people have been talking about these concepts for quite some time. And the quote from 2010 was talking about newborn screening. Given this variability, they were talking about data variability. It's difficult for system developers to capture newborn screening results efficiently and for registries to compare data across programs to analyze newborn screening information. And that was, what, 13 years ago. And so I'd argue it's about time that we move forward with this. So next slide, please. So now moving from data to displays, in EMRs, so there's a number of different benefits here, much like standardizing stop signs. So first, you can reduce usability and patient safety problems. We'll see a couple of those coming up in the presentation. And this is true for clinicians, particularly those who practice in multiple locations. And then the next two bullets really talk about one of the problems we all have, and that is training us on or educating us on how to use EMRs. We can't really train medical, nursing, pharmacy, and other students and residents on EMRs because we don't know which one they're going to be using. And when physicians and nurses switch facilities, get hired in another place, even if they're using the same EMR, it's kind of like knowing Spanish, but then moving to Italy and having to learn Italian. Both Romance languages, both use the same base, but they're not truly interoperable. And now that we've added patient reporting to patients, having standardized results displays could actually be beneficial, because as you can imagine, patients are going to start to see what's in the EMR. And if that's different in every EMR, well, there again, we're going to have confusion. So next slide, please. So there are additional technical benefits as well. If you're a builder of a newborn screening system, you can develop one system and deploy it everywhere, and just the states can pick the individual items in the panel that apply to them. EMR vendors could build tables once to receive newborn screening data from really any state, and then with standardized displays, they can do standardized tracking and clinical decision support, which is pretty primitive when it comes to newborn screening at this point. Individual builds of displays at each healthcare organization could be significantly reduced with standard out-of-the-box reports. And upgrade testing costs, I would hypothesize, could be significantly reduced, because you're not testing against custom-built work, you're testing against a standard data flow and report display. So next slide, please. So let's start out on this by looking at where we are on blood spot data standards. Next slide. So we're still a long ways away from standard data reporting. Just as an example, programs use different names for test results. Hypothyroidism can be any number of different things. TSH, T4 low, TSH elevated, and many more. Quantitative results are reported differently, numbers, ranges, percentiles. Some states report results for individual conditions and tests, others provide grouping, but of course there are differences in the groupings across the states. And we even use different words for what we do. We use neonatal screen, newborn screen, metabolic screen. We call them diseases, disorders, conditions. And yes, it's like early traffic signs before standards. And on the right-hand side, courtesy of Amy Gavigliano, who's also contributed to this, is an example of how we represent gestational age in our data. So next slide, please. Back in December, I did a review of the New Steps database, and there were 20 states that had reported in some detail at that point. 90% of them used LOINC. Only 45% of them use SNOMED, and 40% of them reported still using local codes. Of those, in those programs, only 47% said they could send HL7 results, and only 36% could accept orders. And so even though you might have data standardized, if you can't electronically move it, that's a problem. And so without the C data, you can't translate them into actionable displays. Again, the ability to do clinical decision support. So next slide, please. Just as an aside, even HRSA's patient-facing web page shows this problem. So down the bottom, results can be in range, also called negative, normal, low risk. This is what patients are seeing. Out of range, and you can see all the different ways that people are describing these things. And so rather than just simply picking one way of describing things, we're having to just translate all these different things to our patients. So next slide, please. So now let's talk about how variations in formatting displays that are seen by clinicians. So next slide, please. So this is what I call my dream. And it's almost a dream because it's not electronic. If it was electronic, it would be truly the dream. It's a single page report. And on that report, it shows the result for the various categories of testing, and it also shows you the For those that are abnormal, it describes under analyte the particular thing that is abnormal, gives you the analyte result. And then down below, it gives you particular notes that are useful in the management. So everything in a single screen. So keep that in mind as we move forward to what life is like in EMRs today. Next slide, please. So before we go into that, I just wanted to point out that EMR showed newborn screening results in two different areas primarily. One is called the results tab. We'll look at some examples of that. And that's useful for looking at an individual patient. If you're going, if you're just looking up one patient, that's how you would probably do it. But the second is called the inbox, and that's where clinicians receive messages and typically handle the results. So where I work, we receive anywhere between 50 and 70 newborn screening results a day. And so having to find each patient, click into their results tab is extremely inefficient. And so we get those in our inbox, and we'll look at the usability of that. So next slide, please. So this is the results tab, and Craig, if you could click first for the left-hand side. So you'll this is a sample of a results tab. So you have to know where to find what you will need. And so locating newborn screening results is not intuitive in these sorts of displays. So you'll note that in this particular institution, the category of other tests exists. Oh, by the way, there's an others as well. And newborn screens are several levels down. And if you click here one more time, Craig, you'll see that if you have an abnormal result, you've got to click on it, unlike to get what's behind the abnormal, unlike the example one-page report. And some EMRs have hover capabilities to see the data without clicking. Many do not. So let's go to the next slide, please. So here's another example of a results tab. And it's laid out completely differently in terms of its display. If you could click just one time, Craig. My point here in particular is who in the world would think to look under esoterics for newborn screening results? So again, if you live in this land or this place and you practice there every day, you probably don't think about it at all, just like the yellow stop sign. But if you're traveling, say as a nurse or a doctor or a PA or a nurse practitioner, you probably would, you'd be hard pressed to say, I'll find newborn screening results under esoterics. So next slide, please. Now, the inbox, we're going to move over to that, and you're going to see what I see in my inbox, which is for every patient, there's 7 screens with no clue as to whether there's multiple positive screens. So if you click just once, Craig, you'll see that in this, the very first page says, oops, something's wrong, something's out of range, there's an abnormal, but doesn't tell me what it is. So move on to the next slide. Or sorry, yeah, next screen, not there. Next one, not there. Next one, oops, there it is. So hemoglobinopathies, this patient had a probable C trait. But wait, next one. Wait, there's more. So as more conditions get added, there's more screens that come up. And so we've actually had the case in our institution where a child had an abnormal result at the beginning and an X-linked adrenodystrophy result, which actually got missed, sadly. Luckily, it got picked up eventually, but these are the sorts of things that make this more difficult to use and actually has patient safety components. So let's go to the next slide. I asked around and I got some samples from other places. And yes, this doc seems to have it worse. They have 9 screens to go through. But luckily, the way their system is configured, on the second page, and on the first page rather, I've blown it up so that you can see that very early it tells you. Actually, it's on the second page that here are the 2 things: hemoglobin and there's a post-transfusion state that was abnormal. So it tells you right up front where the problems are, so that you don't have to go scrolling through. Okay, next page. Yeah, thank you. Now let's look at variations in displays for point of care and hearing and CCHD, critical congenital heart disease results. Next slide. So if you thought there was variation in how blood spots are reported, well, point of care testing everybody does it differently. If you've seen one, you've seen one. My findings from the limited research that I've done, but it's enough to know that useful details of testings are frequently not reported to clinicians. And if the results are transmitted at all, which they should be, but frequently aren't, to other organizations, the content of what gets transmitted is widely variable. So next slide, we'll see some examples. In some organizations, they'll build clinicians special reports. This particular organization has built something on the summary tab. If you could just click once. That's good that they have a summary tab for this, but you have to know that the newborn screening results are hiding under newborn nursing Cardex and under the summary tab and not under the results tab. And in this case, the oxygen saturation is missing. Some clinicians like me think that's very important. And I can say in all these things, search functions are being put into EMRs and they're improving things, but they're still pretty primitive. So next slide, please. And click once. Here's another example and click again, please. Of a special report. I didn't copy the whole page just because it was difficult to do so. But here, this is a special report that's been done for clinicians. It says that the hearing screen and CCHD screen were passed, but it tells you nothing about the details of them other than the time that the test was actually done. And the timing isn't so important. It's actually the age of the child is what's important. So next slide, please. And in other organizations, they haven't built reports, but what you have to do there is you have to go to the data entry flow sheets. This is where the nurse or the technician puts the data in. Again, you have to know what it's called. In this case, you have to know that the thing is hiding under NICU discharge. Where I practice, there's a special flow sheet called hearing and another one called CCHD, makes it easy. But in this organization, it's under NICU discharge. And here you can find more details of what's actually done. So for example, down at the very bottom, you can see the pre and post ductal oxygen saturations. So next page. So are there steps being taken to improve things? And next slide, the answer is yes. So let's go back through the sequence again. So blood spot data, the Amy Gavigliano, Brendan, and others are working on standardizing result descriptions. Next slide. And I owe these slides, if you click once, please, Craig, to Brendan. There are efforts to kind of come up with a standardized thing that's similar to the one-page description that I've shown. It doesn't include the CLSI proposed wording yet. But folks are thinking about this. Go ahead, next slide, please. There's another way. There are several other ways. I'm not showing you all, but you could also do what I call the quantitative results approach. And this might be useful for specialists because because it gives you something that's got a reference range and the resultants and the specific analytes. It's much more detailed. Of importance, I would always argue that the results tab and inbox display should be the same in terms of what you're seeing as much as possible. So next slide. And now moving on from blood spots to point of care displays, my proposal is that for hearing, we ought to be reporting pass and refer by ear, the method that's used, which is rarely reported. There are two different types of methods, radically different. The time of testing, the age of the child, in terms of the age of the child and what follow-up is needed. Similarly with CCHD, pass, fail, the algorithm used, again, there's more than one, age of the child at the time of testing, and then pulse oximetry values with the extremity tested. And using simple steps like standard names for the display and standard locations, like saying, for example, this is going to always be located in an EMR under hearing or CCHD so that folks know where to go as opposed to things like esoteric or NICU discharge. Next page, please. So this is a massive, as you can guess, but important job. And it would have been nice, perhaps, if around 2005, that had I been thinking about this, and maybe we could have had it all done by now. But sadly, I wasn't. And there are folks who, just before we go into the recommendations, I wanted to say I'm not alone in this. In the pathology world, there is a small group that's actually lobbying for standardized results displays across EMRs. And they haven't gotten the traction that I think they should get yet, but it's important to know that folks are thinking about this. So some recommendations. First, I would say, yes, I've proposed some things here, but if you ask another pediatrician, perhaps they'll have different thoughts about what should be included. We need to get our a steering work group together. I've suggested the American Academy of Pediatrics, other organizations, to develop a roadmap really of what's needed to achieve standardization of newborn screening data and displays. And then for number two, for data standards, I think there's some excellent work going on there. Accelerate those work groups that are already developing standards, so that we can say this is the way that the data needs to be recorded and reported. And then for displays, forming subgroups for blood, hearing, and CCHD to develop standards for each of these. And a lot of times I hear, well, the federal government is going to tell us what to do. I would argue that the federal government, I say will never, well, it might be 2050 before they reach this level of detail. And we need to be moving forward where we can through our own professional organizations and other organizations. And then four is developing a plan for incentivizing newborn screening state programs and hospitals and clinicians to adopt these. So I want to give a shout out to Catherine Lusk and the Texas Health Services Authority. She runs what's called a collaborative. She's brought people from pretty much the entire state of Texas, all sorts of disparate EMRs, and they are standardizing. They're talking about and standardizing things. Newborn screening happens to be one of their initiatives. That needs to be done, my pitch, on a national level, because just because we're doing things in Texas doesn't mean that we're doing things that the way the whole country should do them, and we need everyone's input. And two caveats: Rome wasn't built in a day, and the famous journey of 1,000 miles begins with one step. This is a long but important job. And I can make a case for federal or philanthropic organizations to support these efforts. So next slide. And perhaps the newborn screening data and display standardization can be quicker than stop signs, because the first stop signs were posted in 1915. And sadly, it wasn't until 1954 that the manual came out that mandated all stop signs be red and octagonal. So with that, I'll finish up with one last slide. And this is my email for those of you who would like to contact me. This is my pitch. Let's dream, plan, and build. And on the left-hand side, these are the trees in Houston. They're live oak trees between Main and Fannin Streets. And when I took this picture, I thought about how 40 years earlier, somebody had planted saplings that were probably ugly, but they have grown into this beautiful picture. And that's what we need to do for the future of our children. So I'll stop there, turn it over to Dan, and I appreciate everybody's time and efforts. Thank you.
Thank you, Dr. Joe. And I'll start by saying you really hit the nail on the head there, showing the variation and the level of variation that is available across different EMRs, different implementations of the same EMR, the various lab systems that are contributing the data on the sending side as well. That's part of the reason why this is a very large project. So being thoughtful, deliberate, strategic, and long-term in the planning for this is going to be a key to success. Other similar initiatives, for example, in California, their cancer registry in California used a multi-year project to get electronic reporting of pathology results directly to the cancer registry, because they found that with manual reporting, it was taking them about 2 years to get statistical significance in their data. And so they found they were unable to do anything useful except report on the cancers that people had several years ago. And so with real-time reporting, after a 3 to 4 year project, they were able to get that to a point where they can evaluate in near real time, are there active cancer clusters forming that need to be investigated? Are there unusual cancers that would benefit from special treatments? How to align providers and patients of like conditions. And it took a while, but it was really gratifying to see the outcomes and be able to watch the healthcare experience get better for patients and providers and for everybody else in the ecosystem as well, registry, reporting, analytics, and the whole thing. So we've seen the pattern. We know it can work. All of those recommendations are pretty much the roadmap of what we're looking for, and it's a matter of how to make it happen. Now, how to make it happen is a really interesting question, and there was a lot of arm wrestling that's going to be going on. So, for example, I'll add in a little spice. That nice table that Dr. Joe showed, the quantitative grid of result values for the specialists, that's great on, yeah, thank you. That's great on a 22-inch widescreen display. Now, imagine that Dr. Joe is on the move or getting between appointments, and he's trying to check those results on his phone or on his smartwatch. That kind of result display isn't going to fly very well. So one of the things that's important is, as we move forward, having the thought leaders, the professional societies, I think, are really well placed, AAP and several of the others. So that's about the most valuable input we can get as system developers and system implementers, is to get functional result requirements. What do you need to have happen at any given point? And don't worry so much about exactly how to do it. Let the system developers worry about how to make that happen. This has been a very common refrain in the lab space as well. Meaningful Use 1.2 in particular had some requirements about transmitting lab data from the regular lab system to the EMR. And some of those requirements that were being placed at some points along the way were going to necessitate maybe a literal interpretation of showing the actual data that was sent over the wire from the laboratory system to the electronic medical record, rather than allowing any provider friendly reformatting. So the best intentions also have a risk of backfiring in terms of being overly specific with some of the requirements there. That said, most of these are not really hard problems to solve as far as hard problems in healthcare interoperability. There are many, many harder ones out there. These are manageable, and the other challenge that this kind of work faces is simply prioritization and incentivization, as he points out, not just financial. Even if there is money available to do the work, sometimes it's a matter of scheduling or just not having enough people available to do the work at the right time. If you're looking at healthcare organizations, none of them are rolling in extra staff at the moment. All are trying to recover from COVID, trying to recover from changes in the industry, prioritizing other new projects, other optimization requests, strategic merger and acquisition work, basic keep the lights on work, like upgrading their system on a regular basis to stay current, to stay safe. And some of these projects require a cross-disciplinary team. So to implement orders and results with a newborn screening lab integration, you'll need up to, I'd say, 5 different people at a healthcare organization. You need an integration team member, you need at least a core medical records IT analyst, you need a clinical SME, you need networking because it's extending out past the hospital's network edge, and so they need to ensure that that's secured, and somebody running a project management role at least. And so getting all of those people together and juggling those against the other priorities of each of those teams and sets of resources is not an easy task. And so even if the labs, even if the local governments are ready, willing, and able, it takes a fair amount of effort to align all of the different provider organizations on this as well, and just be able to do it, even if everyone agrees that it's good work to do. So I think those are really the practical challenges that we face here. Other than that, though, all of the analogies are spot on. The need to be able to standardize the data, to standardize the structure, especially the terminology. Another great example I'd like to add in there just to help drive this home of what we can do with better data is microbiology results. So patient has a wound culture and you want to know what kind of bugs are in there. 20 years ago, you get a textual blob of results coming back. Maybe you get a formatted table, but it's still a big text blob and it's not really programmatically usable at that point. A provider still needs to get the result, put eyes on it, think about it, interpret what's there, and go figure out which antibiotic to get the patient and how to get it to the patient effectively and cheaply. Now, if we have discrete, well-structured microbiology susceptibility results, it enumerates in standard terminology what bug the patient has, bug or bugs, what medications are going to be effective, are going to be most effective for the patient, and we can even then cross-reference those against which ones are on the hospital formulary and going to be most cost effective for the patient and or in stock, and tee up an order all ready for the patient, and the provider just has to click sign or accept or whatever, right? The EMR has the ability to do all of that work, to figure all of that out. The decision support abilities are pretty impressive when you have good data, but when you don't have the data there, it really leads to the provider burden, to the provider burnout that the whole industry is challenged with right now. So not only are there direct benefits here, there are many other benefits to standardizing and improving the digitization of this content for everybody in the ecosystem. So I'm with you 100%, Dr. Joe.
And Dan, thank you. Those are excellent comments. I did have one thing relative to prioritization. I think where we are at the moment is we're trying to standardize all things about traffic all at once, and we haven't yet gotten to the point where we're saying, well, let's focus on this. And when I say let's, I really mean multiple different, all the different groups that are involved in this. So something as audacious as this is, all the vendors, all of the states, all of the professional organizations saying, one of our key priorities is going to be X, and all working together, because everybody's working on everything, and we're all getting 5% of everything done, because nobody is working on things, and not everybody is working on everything together. And so Rosa from the AAP brought up a concept that's used within the American Academy of Pediatrics, and that's a resolution. They have a governance process within the AAP that informs their board as to what's important. And so while I didn't get the resolution into this year's cycle, getting it, starting to socialize it, et cetera, is a way of getting the American Academy of Pediatrics behind it. Now, I suspect within the states, there's an organization of state newborn screening programs. Within vendors, there's an organization of vendors, et cetera. And sort of marketing this concept to them is something that, frankly, I would put on my shoulders and that of others, because that's the way that change comes from catalysts, who want to make the change, and enzymes, but it's the marketing of those changes that is terribly important. So thank you.
All right, thank you both for some great content and some great ideas there. We're happy to open it up to the audience now. If you've got questions for either Joe or Dan, please either put them in the chat, or you can raise your hand or just come off mute and ask your questions.
Hi, this is Stan Trujillo from California. Just had a question for the last speaker. Could you repeat the 5 people that are needed by the hospital or HMO to organize this?
Oh, sure.
What are those titles? Because we're asked this all the time. What do you need? And this is very helpful. This was very helpful.
Sure. It probably varies a little bit,
Yeah.
but I would say you've got an interface analyst who's actually doing the HL7 work. You'll need somebody from the hospital's network or cybersecurity team to establish the VPN or other secured connection off the hospital network, at least briefly, not necessarily for the whole project. You'll need at least one clinical EMR analyst to do the configuration of how it displays. So the several different examples Dr. Joe showed, those are all generally fairly configurable in most EMRs. You'll need a clinical subject matter expert of some sort, a Dr. Joe, or laboratory rep potentially as well, to ensure that the data is coming from the lab appropriately and displaying in the EMR, but at least one clinical SME. And then generally somebody playing a project manager role to ensure that all of the individual tasks get done, manage meetings, make sure that everything gets done, crack whips, all that kind of thing.
Okay, that's very helpful.
And Dan, I think you can't really underestimate that clinical person. They not only have to have the knowledge of things, but also be able to work with their colleagues, and because a lot of these things may entail changes to the workflow. And so I think there's probably a lot of championing that goes on as well, right?
A clinical champion is a great way to phrase it as well.
Yeah.
Not just a subject matter expert, but a champion, because you're right, there may need to be engagement from the organization's training team if there's a workflow, to make sure that all of the users, if it's just one, you can tell them pretty quickly and you can show them in an afternoon. If you need to organize training for, say, dozens of nurses, handfuls or dozens of physicians, that's yet a more challenging project. Or the communications team to get documentation ready of what the appropriate policy and the appropriate way to use the system is in these cases. So the rabbit hole goes deep pretty quickly.
Exactly. Yeah. So the champion issue is good. We just started doing orders in California for health services for NBS, and we found the first group that we worked with became our champions, and we trot them out for the next the next few organizations we've been enticing into going live with us. So champions are very helpful inside and outside the organization. Okay, this is good. Thank you.
All right, thanks, Dan. And yeah, I think being able to leverage what you've done at one site with another, particularly if there's a common system involved, either the lab system or the EMR, is something we've heard is very successful. We'll
And
go to
I'm-
Brendan and then
Craig,
Yeah, I'll just say
quick-
one thing. We have to thank Texas because the first champions we used were from a hospital in Texas to entice the first hospital to onboard with us. So yeah, pay it
Excellent.
forward, you know.
That's right. And Craig, I'm going to jump in real quickly
Yeah.
here. Stan, your point about standing on the shoulders of others there is really a good one. And I'd like to encourage anybody trying to do programs like this to be collaborative and work with the EMR vendors or anybody else in the mix, state level organizations as well. I have certainly found several different projects where there were initiatives from local public health organizations to improve their integrations with the providers in the area. But I didn't know about it for 2 years, and it turns out there were a lot of headwinds that I really could have helped work around for the organizations involved. I can't tell our customers as an EMR exactly what to do. I can make recommendations on how to accomplish it and what things are effective, but I can't prioritize their work for them. However, I can also help them understand how to most efficiently get it done. I can share communication across the organizations. I can help facilitate documentation. I can translate between one organization. The public health lab may say something one way, and that phrasing has a different meaning to the provider organization, right? So you've got to know how to say the right thing to the right people sometimes in order to get these projects off the ground as well. So by all means, please look for opportunities to include the vendor to help facilitate this, again, in the interests of making everything better for our patients and our providers.
All right, thanks, Dan. So Brendan and then Wendy, you'll be next.
All right, thanks, guys. And thank you guys for this presentation, Dr. Schneider. You know, all this discussion of standardization is something I'm really passionate about as well. I just wanted to bring up a couple of things, right? And I think the discussions about, the parties involved on the healthcare provider side of things, the different folks involved there, that was right on. And you talked about the clinicians or, nursing staff or laboratory staff on the programmatic side to work it into workflows and make sure that, that the things are configured the way they need to be. And also from the vendor standpoint, as well as the public health laboratory standpoint, we can help our partners implement these things, but we can't dictate to them what they're going to do and what their displays are. And so I think all of those things kind of lead to some of the challenges, Dr. Joe, that I think you're mentioning in terms of the standardization of the display of these results. The one thing I was going to say is that we looked at some of the examples that Dr. Schneider showed of the display of results in the EMR that he's using, and we have, I think now 8 additional interfaces with that same EMR. It might be 5, it might be 6, sorry, somewhere around there, but they're all a little bit different. And the messages that we're sending from our system that's being consumed on the healthcare provider side are exactly the same for every one of those. And so when we get these different folks involved to decide how they want these displays to display and how it works for their system, and we have great partners in this regard, and that is absolutely really huge and helps the projects move forward. But we have seen that the decisions that they're making on their side are a little bit different every time. So all that said, if there was some sort of standardization and some higher level discussions with the AAP and newborn screening programs about how these things should display in EHRs, I think that would really streamline a lot of these projects and getting these things into place. And the last thing I was just going to note is on the data standardization and Dr. Schneider, you mentioned this, that, within the newborn screening programs, we are like proposing some adjustments to the standards to make them, a little bit simpler. But this is from the informatics side of things. And I know I've said I sound like a broken record on this, but from the informatics side of things, the best we can do is map the standards to what all the different programs are doing. So the first stage in standardizing electronic reporting is getting standardization from programmatic level in terms of, are we sending qualitative or quantitative results? Are we using the same terminology, abnormal, normal, unsatisfactory screen, positive screen, negative for the same thing? So I will stop there. I could go on forever. You guys know how I am. So, but regardless, I appreciate all this presentation. It's and these thoughts. It's a really important stuff to think about.
And Craig, before we go on to Wendy, just about 40 years ago, I was an accountant for quite a number of years before I went to medical school. Accounting had the same sort of problems that we're talking about. Everybody was doing things differently. And they solved that problem by creating what was called the Financial Accounting Standards Board, which basically was the organization that Dan and Brendan are missing, which is basically, it's the organization that says, this is the way that things need to be done. And so we can say, well, gee, that's the federal government, but I don't think that's going to get us there. I'm suggesting that we, in essence, create the newborn screening standards board. Obviously, I'm thinking about things beyond newborn screening as well. But we start with creating the organization that can say to clinicians, to hospitals, to other organizations, this is the way it needs to be done, and getting enough respect for that so that, in fact, folks do it that way. So stop there, and if there's other comments, otherwise on to Wendy.
All right, let's actually go on to Wendy so we make sure that she gets a chance to be heard.
Hi, everyone. Hi, Dr. Schneider. It's nice to see you again, and thank you so much for your presentation and for Daniel and Craig's contributions as well. So everybody knows Brendan. I actually work for Revity, which was PerkinElmer, and I worked for Oz Systems. So if you wonder if I get a little confused about who I am, we've had a lot of name changes recently. Anyhow, the question that I have is about direct mapping of results back. So we have been very successful in helping hospitals send that electronic lab order. That seems to be running smoothly, easy for us. We've got that in the bag. But the direct mapping of electronic results is always challenging. And I think I have a couple of questions here. One is, like Brendan says, every hospital is different. Trying to get all the fields in and we work a lot with Epic, but anybody is challenging. And one thing that I've heard is that, the nursery is not a moneymaker for the hospital. And maybe Dr. Schneider, you want to comment on that, but they are kind of low man on the totem pole, for other departments that do bring in more revenue to the hospital. And the other thing is this topic of health equity. And how do we address these smaller hospitals that don't have sophisticated electronic health records? And when we've tried to direct map back the results, it's been cost prohibitive for them to even build it out to be able to send the place or order number or the session number to be able to map back the results to the specimen they sent, as well as being able to consume those results. So how do we get over these hurdles? And then my last question, sorry, I'm kind of throwing a lot out there for you at the last minute, but is direct mapping necessary? You know, would a electronic PDF be sufficient? And are we killing ourselves trying to do something so sophisticated that may not be necessary to the end result? And I'm done.
Can I do real quickly? One is no, newborns aren't money makers, but they are the beginning of the process. It's an easy way to say this is where we start because this is where life starts. And oh, by the way, they are attached to NICUs, which frequently are money makers. The second and third one, from a health equity standpoint and a mapping standpoint, if I could magically take you forward and all the data was standardized, all the reporting was standardized, your EMR would come with a map already built in that would connect everything, all the standard pieces together. So I can't see whether Dan is laughing at this point, but hope at least I'm bringing a smile to his face, and I'll turn it over to him.
Yeah, that's a great direction to be looking. So standardization, not just the fact that it's out there, but that it's agreed upon and endorsed as a best practice by the professional organizations, by national organizations, whomever, so that the consumers of the medical record system, the consumers of the workflow, the providers in any individual organization demand to be using the best practices. That's part of how we get there. And so it really does kind of need some of that leadership level. But certainly as a mechanism, yes, having the EMR or laboratory system or any other information system come preloaded, once the right way to do something is known, that's a standard practice for us. We do have a pre-built system, and every new Epic customer gets a copy of all of our current best practices already built in the system, and then they tweak it to their own organizational needs. But there's a lot less variety than there used to be. There's a lot more best practices known that we're trying to help all of our community members stand on each other's shoulders. So the job can get easier over time. It doesn't solve all of the problems, especially for the systems that are already out there. That's not necessarily any easier in some cases. Some cases it is. That's going to be a little bit technology specific, vendor specific, but absolutely that's another reason to keep engaged with the vendors involved, the information systems, as hopefully the groundswell of support for this change comes. We can also help facilitate that and make it easier for everyone, hopefully. That's my goal.
All right, and I think we'll end on that positive note as we're nearing the top of the hour. So if you do have additional questions that you weren't able to get asked today, feel free to reach out. We can put you in touch with the right people and try and facilitate some discussions. But I did want to give both Joe and Dan a big thank you for being here today and doing such a valuable service to the community, and thanks to everyone who was able to join us. Joe did actually hint at something early on, that this is actually one of our last INDSI webinars. Our project will be wrapping up later this summer. And so our last two webinars are going to be a little different. Rather than focusing on specific topics as they have for most of the last 3 years, we're going to be doing a wrap up. We're going to be looking back at some of the lessons learned that we've gathered over the last few years of working with all of you. And we're going to be hearing from some states about what interoperability holds for them going forward. So it's been our privilege working with all of you in these states, and we hope that you'll be able to join us for these last two webinars. They'll begin at the regular time, the second Wednesday of the month at 3 p.m. Eastern, but we're going to supersize them a bit so we get you a little bit of extra content in there. So there'll be 90 minutes rather than the typical 60. And you'll be seeing something in your email shortly on how to attend these webinars. And so please keep an eye out for that. And hopefully this will be a fun and informative way to wrap up the project over the summer. But in the meantime, if you do have any additional thoughts about what we discussed today or want to learn more about what we've done or what we're going to do in the last few months, do please reach out to us. You can always reach us at nbsinterop@altarum.org for more information. And with that, we'll let everybody go. Thank you for attending and hope everybody has a great rest of their day.
Thank you.
Thank you.
Thanks, y'all.
Thanks for joining, everyone. Take care.